I'd like to warmly welcome Dr. Will Lester, who's a haematology consultant at University Hospitals in Birmingham.
Very good. Right, so we're going to start off with a practice question. If you've just joined us or you think, oh, what's happened to that screen? At the bottom right-hand corner, you can still see that you type in kahoot.it in the game pin. So it's never too late to join. Right, I've got some disclosures relating to various things to do with mostly companies that provide anticoagulants. Right, so let's start with a practice question. What is the national animal of Scotland? Is it a grouse, a Highland cow, a haggis, or a unicorn? On your phone, you'll have different pictures and you have to press the right color with the shape to get to vote. So the right answer is the unicorn. Most of you thought it was a Highland cow, which makes sense, or a grouse. The haggis isn't an animal, but anyway. So that was just a little practice run, okay, before we actually ask the proper questions. So that's not me, whoever that is. Is that you, Sylvia? Yeah. No one's got any marks, but for some reason you're at the top of the leaderboard. So let's start with a case. So this is a case of a 48-year-old woman who presents with a headache and vomiting 12 days after the AstraZeneca COVID vaccination. And imaging reveals a cerebral vein thrombosis with secondary hemorrhage, which is not uncommon. And in terms of lab reports, we've got a platelet count of 28, a fibrinogen that is not normal. I guess most of you would know that the platelet count's low. The fibrinogen is also low, and the D-dimer, which is a test you commonly use for screening people at the beginning of a suspected thrombosis and then possibly afterwards as well, is very, very high at 42,000, with normal being up to about 500. And they also have this antibody called the PF4 antibody, which is the commonly screened for in a condition called HIT, but also is often positive in these cases. So I'll ask you a couple of questions that you won't necessarily know the answer to, but you're going to have to take a guess. So what is the current predicted mortality from that presentation? Cerebral vein thrombosis with hemorrhage with a platelet count less than 30. Is it less than 10% of patients' mortality, 30%, or more than 50% in this situation? So it's actually more than 50%, which is why a lot of people are talking about this condition at the moment and making sure that these patients are picked up really early. So the earlier we can pick people up and the earlier we can start therapy, the better the survival chances. So this is historical mortality in this situation. And I think it's an important point to make that it's all about early recognition and early intervention. And most of you did get that. So there is a sort of leaderboard as we go. So walk is ahead at the moment. And we have another question, true or false? Heparin can't be used in this condition as it makes it worse. True or false? Heparin can't be used in patients with this VIT because it makes the condition worse. True or false? The answer is actually false. We've got no evidence to say that heparin makes this condition worse, but because it's so similar to HIT, all the advice has been not to give heparin, but actually we don't know. There's actually no actual scientific, but there's no proven basis for this statement. So we have talked a lot about whether we start to allow heparin use, but how we do that, because we're very nervous about using it. So unfortunately, we're not using heparin, but it's not because we've got evidence, it's because it's so similar to HIT, we're worried. And I guess that's something that people don't necessarily realize, that some of these recommendations are based on sort of assumption, because it's such a new condition, we haven't had a chance to work out what's best. So we've got Anna at the top here at the moment. Well done, Anna. So current management strategy is IVIG, because it seems to be an antibody-mediated problem, and that seems to help. Steroids, we don't know if steroids help, but we think they might. A non-heparin anticoagulant, because we're worried about heparin, even though we've got no evidence. You can give a platelet transfusion if you need neurosurgery, but we avoid them otherwise. Plasma exchange for the difficult cases, and rituximab as well for some of the more difficult cases. So it's a very new condition. So anyway, the patient survives and is improving on the ward, and they're on Thunderparanox, which is a heparin alternative that often is used in HIT. And that's a therapeutic dose, 7.5 milligrams daily. So you give them a patient information leaflet, because there's one available on the BSH website, all about the condition and everything. It's very useful. If you haven't used it, download it from the BSH website and give it to your patients if you have any. You arrange to monitor the full blood count, D-dimer and PF4 antibodies to make sure there's no relapse. But what anticoagulant are you going to choose for this patient? Because you don't really want to send them home on injectables, even though it is potentially the right treatment. Is that the case? I don't know. This is the quiz. So this is a poll, there's no right or wrong answer here. Are you going to use Warfarin, a direct anti-10A inhibitor like apixaban, edoxaban, or rivaroxaban, dabigatran, or Thunderparanox? Is this someone with a cerebral vein thrombosis? Happens to be triggered by this bit, but in some ways, is that important? Does it matter what the trigger was? What anticoagulant are you going to use? So we got no one for dabigatran. So we got some warfarins, some anti-10 agents, some Thunderparanox. One of the guidelines that's come out from the States, I think, or ISTH, talks about using Thunderparanox, but I must admit in the UK, we're tending to switch to orals at discharge, and some people are using the 10A inhibitors. Some people might want to use warfarin, and that's because warfarin is a traditional treatment for cerebral vein thrombosis. None of you said dabigatran. We have sent all our patients home on dabigatran, actually, and I'll explain why. So cerebral vein thrombosis, now, this is a bit about this condition. Traditionally has always been given warfarin. Until more recently, there's not been any trials of Dirac, but actually there have been now. The 2017 European Stroke Guidelines did recommend against the use of Dirac, because there were a couple of tiny little studies with some anxiety that they used to justify that. But subsequently, there's been much bigger studies where people have used different anticoagulants, including the 10A agents, showing reasonable efficacy and safety. So people are getting a bit more confident about it. But there is a published randomized trial comparing dabigatran and warfarin. They all have a heparin lead-in for at least 5 days. But in the study, they randomized dabigatran and warfarin, and they had equal efficacy and safety. There is another rivaroxaban study in progress. It's not been published yet. So we're moving, I think, towards being a bit more comfortable using DOACs in this situation. And the reason we've used dabigatran is because it's got a good antidote, and because there is a trial, a randomized controlled trial. But people are using all different things, and there's no right or wrong answer. That was just a poll. So I know this is not exactly VTE, but I just wanted to ask you about something very, very current. I wanted to quiz you about something very current, and that's the new NICE guidance. There's only one question, but see what you think. This came out, not long, last month. So what bleeding score does the NICE AF 2021 score guideline recommend? Is it HAS-BLED, ORBIT, REAT, or ISTH? Which bleeding score in the new AF guidance? A lot of EB will be familiar with at least one of those bleeding scores. Very good, very good, very good. It's ORBIT. I bet a lot of you I'd never heard of it before NICE recommended it. It seems as if HAS-BLED had its day, maybe not. Who's there? So we got AK. Very, very good, very good. So ORBIT is like a sort of slightly simplified HAS-BLED. So it just includes gender, sex is the right word now, age greater than 74, a bleeding history. Obviously, a bleeding history is always a good predictor of bleeding. Renal function as calculated by GFR less than 60, and treatment with an antiplatelet agent. So you're always going to try and stop an antiplatelet agent if you can. It has been validated in patients on DOACs as well as warfarin, which is one of the things that people like about it, and it's relatively simple. And this is just one of those online MD calculators that you can fill in. So let's go for another scoring tool. Okay, this is to do with thrombosis, and this is the DASH score. And you'll have at least heard of it, and it's recommended in the new NICE VTE guidelines. So we have a 45-year-old male with an unprovoked DVT, and he decides to stop anticoagulation after 6 months. He's a keen sportsman, likes sort of sports that could involve injuries, is worried about anticoagulant-related bleeding. But you do a D-dimer a month after stopping the anticoagulants, and it's 590, with a normal range being less than 500. So what is his predicted annual risk of relapse according to the DASH score? And this is using the MD Calc online calculator. So what is the risk? What is the DASH predicted annual risk of VTE relapse? This is the annual risk, 3%, 8%, 13%, or 20%. Oh, it's a good old mix, isn't it? The actual answer, would you believe it, is 20% using the online calculators, which is higher than I would have expected or would have quoted to the patient. Normally, I would quote to a patient with an unprovoked clot, although this is general without being age or D-dimer specific, is for a male would be over the next 5 to 10 years would be a 40% chance of relapse over 5 to 10 years. But this is a very specific score saying that this is basically, so we see who's on the lead. AK still just keeping it there. So the DASH score, because this patient is less than 50 and because the D-dimer is abnormal and because they're male as well, which gives you an increased risk of relapse, that is what has given the points, and that is what has given your 20% annual risk of VTE recurrence. So yeah, it's quite high, isn't it? I don't know if you reapproach this chap, will he be prepared to modify sports? A lot of sports we don't mind people taking anticoagulants for. I think boxing and kickboxing is probably a step too far. Skiing, you can always skip a dose on the day you go. That's another option, isn't it? So, the most benevolent king communicates through your dreams. Who said that? Was that Shakespeare? Was it the Wu-Tang Clan? Was it Charles Dickens? Or was it Ed Sheeran? Who said the most benevolent king communicates through your dreams? That was a total, basically, clearly everybody took a guess, and it's a good old split there, but it is the Wu-Tang Clan, if you're familiar with their work. Very good. There we go. AK's maintain the position there. Right, next question. Which profile most predicts a stable INR? Because we still have patients on warfarin. It's not all over, is it? A female less than 70, a male more than 70, or an INR target 3.5 in a patient who's got heart failure. Which profile predicts the most stable INR? Fascinating. Right, so the profile that fits the most stable INR is actually a male more than 70. I mean, for those of you who've been around as long as I have, then young people are awful with warfarin generally, aren't they? They're all over the place. But yeah, the most stable, we'll look at the scoreboard and then I'll show you the paper. AK's maintained a pretty solid lead there. So this was a nice paper looking at 12-month sort of outcomes and predictors of stable INR. Good bunch of authors, very trustworthy. And the profile of the most stable is a male over 70. Maybe the most biddable people who follow orders, who knows? The INR, as soon as you start increasing an INR target, you'll reduce stability. It's a fact. The lower your INR target, the better the stability. So you should only push it up if you have to, and absence of heart failure as well. So there you have it. So we've got another case, an 84-year-old man with a previous unprovoked PE, and they're on a Pixaban 2.5 milligrams twice a day. And he's got some persisting upper GI symptoms that are causing a little bit of concern because they're not settling with standard therapy. So the GP books him for an upper GI endoscopy just to exclude something, you know, nasty. So when should he stop the apixaban? When should he stop? And this is using our current national guidance. 48 hours, 24 hours, omit the dose on the morning of the procedure or don't stop it at all. Here we go. A few more seconds. So we've got the most popular choice being 24 hours. It's actually omit on the morning of the procedure, and I'll show you the algorithm. This is based on the British Society of Gastroenterology guideline, and it's just been rewritten. I'm one of the authors, so I can tell you it has not changed from the previous guideline that was written several years ago. Omit on the morning procedure. I did argue for the consideration of 24 hours, but in the end it was felt that for diagnostic endoscopy, which is low risk for bleeding, it wasn't necessary. So where are we? AK, keeping that AK, very good. So you've got this nice little graph. The new one's not that dissimilar. There's a few wording changes. Low risk procedures, so that includes diagnostic procedures. With biopsy, that would include this endoscopy. On a NOAC, omit on the morning of the procedure. Now, if it's a colonoscopy where there might be a polypectomy, that is a high risk procedure, and therefore you would stop for 48 hours. You'd stop for 2 days. The new one says stop 2 days before rather than 48 hours. So that would be different, but this is an upper GI endoscopy, which is just diagnostic. So they can take diagnostic biopsies. Right, it's another case. Now we've got a 62-year-old man with thrombophlebitis in the left long saphenous vein. It's a superficial vein. It is 5 centimeters in length and more than 3 centimeters from the saphenofemoral junction. So you know that if it was within 3 centimeters of the saphenofemoral junction, that's within 3 centimeters away from the deep vein at the groin, you would treat it as a DVT, but this one is not. But it is 5 centimeters in length, which is often a trigger for treatment. A ultrasound is done that shows no evidence of a DVT. There is no clinical suspicion of cancer. What treatments have been tested in randomized controlled trials? That is my question to you. Which of the following treatments have been assessed in randomized controlled trials for superficial thrombophlebitis? We've got rivaroxaban 20 milligrams for 6 weeks, Thunderparanox 7.5 milligrams for 6 weeks, Warfarin with an INR target of 2, or intermediate dose lemeloqueprin. There is only one answer here. There's a lovely picture of thrombophlebitis for you there as well. Right, so this is a bit of a tricksy one because rivaroxaban has been tested in the Surprise trial, but it was 10 milligrams, not 20. Thunderparanox has also been in a trial and is also licensed, but it was 2.5 milligrams, not 7.5. Warfarin, as far as I'm aware, has never been tested at an INR target of 2. And so intermediate dose lemeloqueprin is often the comparator for the other drugs like the rivaroxaban and the Thunderparanox. It's often a comparator, so it's not prophylactic, not treatment, intermediate dose. That's the only one on this list that has been tested. So it's a bit of a tricksy one. I was sort of misleading you with doses there. Anna's sort of doing well. AK needs to worry that Anna is definitely coming up from behind. So we're nearly done now. So we've got a 50-year-old man who presents with an unprovoked PE. He is 140 kilograms. What anticoagulant will you offer? Which would be your overall likely preference? It's a poll, not a quiz, because there isn't a right answer. Are we going to go for Warfarin, low molecular weight heparin, or a Dirac? So I'm not quite sure, maybe I should have explained a bit more carefully, but low molecular heparin, that's, it seems, I would say, a little mean if you're going to treat this man for life, because I guess maybe you interpreted that as what would be the first thing you would give, but what I meant was what would be your treatment option going forward. So maybe I misled there, but yeah, so we've got people who are going for warfarin, presumably on account of the weight. We've got some low molecular heparin people, maybe undecided, and we've got some Dirac people. Personally, I've got absolutely no problem whatsoever giving a Dirac to these patients. The levels are absolutely fine. There's no evidence at all of a problem. What did NICE say in their guidance? They basically, I think, yet again, managed to come up with some utter rubbish. So anticoagulant treatment for DVT-LP in people at the extremes of body weight. They're not only looking at those over 120, which is often counted as a watershed, but also those less than 50. They're saying regular monitoring of therapeutic levels. There's absolutely no evidence for that whatsoever. No evidence for that whatsoever. We did argue the case in the draft, but they ignored that. I think many of us have no problems at all giving set dose Dirac to these patients. The evidence is accumulating that it's not a problem. There's a new guidance rewrite of the ISTH guidance that's coming out, which I think will support that, and will no longer have this very strict 120 kilogram cutoff. So where do most of the world's polar bears live? Canada, the North Pole, Greenland, or Iceland? This may be the last question. This is it. We're going to have a winner after this. It's actually Canada. Would you believe it? I didn't know that until I found this quiz question. It's Canada. So let's have the scores on the doors. We've got a podium. Third is Julie. Well done, Julie. Second is Anna, and first is AK. Well done, AK. And we've got some runners up. We've got Flick and Walk. Very good. And with that, I'll need to work out a way of actually stopping it. So I guess that's it. Over to you, Sylvia.
Okay, thank you very, very much. Just
I don't know if AK wants to admit who they are. Does AK want to put their hand up? Hold on, Anna's just put their hand up. I thought Anna came second. Or is Anna wanting to ask a question? We won't push it on anyway. AK can remain anonymous. No, you can remain anonymous if you wish, but well done. And well done, Anna. Yeah, I can take any questions anyway.
Oh, AK saying Anna is her name.
Oh, right. So you mean that Anna that came second is not AK then? I'm very confused. Did they vote twice? Did they beat themselves? Have they got two mobile phones? Anyway, well done. I'm sure that you'll get a big prize from Thrombosis UK. Bottle of champagne. A virtual bottle. A virtual bottle. But yeah, any questions? I've got
Sylvia, there's a question in the chat one.
Oh yeah, I've just opened up the
yeah.
The
Patients
chat.
with VTE and prophylaxis. I'll leave it to you, Sylvia.
There we go. So this is a question from Kutch. In patients with VTE on prophylaxis, e.g. apixaban, do you treat with treatment dose apixaban or use a DOAC with a different MOA such as dabigatran or warfarin?
Oh yeah, I've got you. So you mean they're on, all right, so say if they're on the low dose, they're on a low dose Dirac and they get a breakthrough thrombosis, are we talking about?
Yeah.
So they'll have a Riva 10 or a PIX 2.5 BD, and then they get a breakthrough thrombosis. I mean, the first thing to do, remember, is that you've got to be really sure that it's definitely breakthrough thrombosis, because there's sometimes people are a bit lazy in ED about ensuring that there's definitely new clot there. You've got to be really careful, because it has implications for the rest of the patient's life if you label them as having a breakthrough thrombosis. You need to be sure that you're seeing new clot. You need to make sure you do imaging. I know in the past people have said, well, it makes no difference. It does make a huge difference if they've had definite breakthrough thrombosis. But if they have had definite breakthrough thrombosis, you obviously think about cancer, think about what's going on, why have they had breakthrough thrombosis, and look for a potential cause. Obviously grill about the adherence as well, because there's so many factors here to take into consideration with breakthrough thrombosis. But at the end of it, if it's probably a breakthrough thrombosis and there's no obvious explanation, then I think it's okay to boost up the dose of the same DOAC potentially. I think it's okay to use an alternative like warfarin potentially. I think it needs a chat with the patient, but you're not going to carry on with the same. You're going to change. So it's either going to be a doubling a dose. I mean, temporarily you're going to give the full dose. You're going to give your. I mean, what a lot of us do in this situation is we temporarily put them on, say, BD heparin, just until we can work out what's going on as a holding measure, and then after, say, a month of high dose heparin, when we think we've got a handle on it, we'll switch them either back to a higher dose of the same drug or an alternative. Yeah.
Okay, so looking at people who have undergone surgery such as gastric bypass or that have short gut syndrome, what's your opinion on using DOACs in those situations?
If you've got virtually no gut, if you're on TPN, I think it's not easy to use a DOAC. So the most severe intestinal failure patients can use warfarin. So we've got a few that are on warfarin, and they can test their own INRs at home if they've got their own testing device. I've got one patient who's on regular vitamin K as well as warfarin, and he gets a lot of stability from that. But yeah, I think if you've got some gut and you do use a DOAC, then that will be a time when I would measure levels. I'm not so worried with weight, but I would measure levels with short gut, just to reassure myself that I'm getting some detectable drug. We don't really know exactly what a therapeutic level should be. There's a sort of guess at what it should be, but we don't know for certain. So yeah, I think a level would be acceptable under those circumstances, because you can't, putting people on heparin forever and ever is pretty horrible, because your abdomen ends up looking like a battleground. There's another question. Can you confirm if you can use a DOAC in patients below 50 with good renal function? Absolutely, yeah. I mean, we've now got the pediatric data for quite a few of the drugs now, and it's now licensed. Rivaroxaban's got granules as well that you can use in tiny children. So a lot of the DOACs have got trials in children. Rivaroxaban was slightly ahead of the others, and you can use them down to people that have several kilograms, basically. You do have to dose adjust, I think, when you get down to about, I can't remember if it's 30 kilograms or something, but certainly you can use adult doses in patients who are sort of, in the 40s. Okay, so those patients are at more risk of breakthrough thrombosis and bleeding, but it doesn't mean you should underdose them.
Okay, so kind of going along with the weight theme then, there's a lot of discussion on DOACs and obesity, but how do you need to differentiate between those with excessive weight due to, for example, bodybuilding, those that are very fit but big build, and those with excessive weight due to other reasons?
And personally, I don't, because I don't think that any of those things are a problem with fixed dose DOACs. I think they're all fine. I mean, the thing about there are differences in the reality that are, a lot of these drugs that are effective in terms of their vascular distribution. Heparin is a good example of this. So heparin is only in the blood vessels, and to some extent the DOACs, and fat is less vascular. So with heparin, when you keep increasing the dose as people get heavier, you'll start to overdose them, because each kilogram of soft tissue or whatever is got less blood vessels in, so you end up overdosing ultimately when you, especially if you're over 140 kilograms. But with DOACs, you know, it doesn't seem to be a big issue, and it doesn't seem to. So the vascularity of fat is less than the vascularity of these bodybuilders, I suppose. But the main thing with the bodybuilders is that I asked them if they've been taking naughty drugs, basically, that have caused their thrombosis, because you know, and it's actually a lot of people are, you know, take stuff to try and build themselves up, and it's risky for thrombosis. So never forget to ask that question, although people are often not that keen on admitting on it because they feel that maybe it's illegal, but it's useful to know, I think, because at least that's a reversible risk factor.
Okay, so looking at drugs and DOACs, can you use a DOAC with carbamazepine or phenytoin?
Yeah, so really good question. I mean, the drug interactions, you know, are not that profound for most patients, especially VTE patients, because a lot of them are not on cardiac drugs. But the biggest drug class is the headache, is the anti-seizure meds. We allow it, but that's one other situation where we measure levels, that we have to satisfy ourselves that the levels are not too low or too high, depending on which drug it is. So we don't count it as a no-no, we count it as a relative caution, and we check a level.
Okay.
I mean, with rifampicin, if someone goes on rifampicin, we just stick them on heparin until they're finished having rifampicin. You can ask if someone's got HIV on retrovirals, you can ask a friendly HIV pharmacist to tell you whether one of the drugs might be acceptable in terms of its interaction. You know, sometimes we've used adoxaban in certain patients. So, you know, so most of the drugs, it's not an issue, but those ones, I think you have to be a little bit careful about co-prescription. But
Okay.
we will allow co-prescription, but we do like to see a level.
And Anna has got a two-part question for you. Would like
Is this
to
the
ask,
Anna who won?
I think she came
Or the
second.
Anna that came second?
Yeah. Should we scrap her off then because she didn't win?
No, because it might be the one that won.
She'd like to ask your opinion about subsegmental VTE and how you would manage these patients.
Yeah, so basically there is a trial being started, and I think our centres have volunteered to be part of that trial. A trial randomizing people to no treatment versus treatment. There have been some other studies as well with subsegmental PEs. The general rule of thumb, I think, is if you've got cancer, we get a bit more nervy about it. If you haven't got cancer, that we think that it's probably something that can probably be ignored. But there is a study that's just starting soon to again address this very important question about these sort of isolated, sort of tiny segmental or subsegmental clots. But we think that you can probably ignore them in non-cancer patients.
Okay. So the second part.
No, that was no. Sorry, I'm getting confused now. No, carry on.
The second part of her question is there's a patient with a history of provoked VTE that's come off anticoagulation and then gets another provoked VTE.
Yeah.
Would you go for long-term anticoagulation?
Not necessarily. If they're both provoked by reasonably strong risk factors, I'd still have the conversation about stopping. I think what's important is, what do you mean by provoke? So if it was something relatively trivial, like if it was just a long journey, you know, then I might, or something, you know, something sort of not so impressive, I might be inclined to carry on. We do know, actually, interestingly enough, but we don't practice this, but we know that the D-dimer actually is predictive of relapse in both provoked and unprovoked. So we use the D-dimer like in the DASH score for unprovoked clots, but actually a raised D-dimer in unprovoked patients also predicts higher risk of relapse, but we generally don't use it because we generally stop it in provoked. But I think there's a grey area from strong provocation to sort of weak provocation, and weak provocations would make me much more nervous. And sometimes the patient will say to you, like, I just don't want to have another one. I'm too scared. In that, you got to take that into consideration. But I don't think it's an automatic 2 clots and you have to go on long term, because it's the context of those clots. Absolutely, because it's a big thing to put someone on lifelong anticoagulation.
Yeah. So if someone's allergic to heparin and DOACs are contraindicated, Is Thunderparanox an effective alternative for VTE?
Yeah, Thunderparanox is generally, most people who are allergic to heparin will tolerate Thunderparanox. So that's an option. And I mean, it depends on what you mean by contraindication. I suppose if it's a particular drug, you know, then you've always got warfarin as an option, haven't you, as well? I mean, I think injectables, long-term injectables are always best avoided if possible. But yeah, Thunderparanox is a bit more pleasant, actually. If you talk to people who take Thunderparanox injections, they say they're a lot more pleasant than heparin. They don't sting as much. They're nicer.
Okay, so kind of going back to DOACs again now, can they be used for single positive antiphospholipid syndrome? So in lupus, anticoagulant only?
Yeah, so I mean, the study that showed that there was an inferiority was in triple positive patients or patients with arterial thrombosis. So if you're triple positive arterial thrombosis, we obviously strongly recommend that you go onto warfarin. But if you're not triple positive and you haven't had arterial thrombosis, there's not really a great deal of evidence of significant inferiority. And so I was one of the authors of the BSH addendum guidance that said that you can talk to a patient about switching, but it's probably okay. And I mean, there was the UK trial with rivaroxaban on stable patients, you know, that showed that rivaroxaban seemed to be pretty reasonable in about 100 and something patients were in the study. And they were mostly not high-risk patients. So we tend to say, you know, we tend to allow people to carry on, because often you don't get this information till they're already on the drug, and often they've been on the drug for more than 3 months and they've been fine as well. There is a bit of, there's a nice paper that's just come out suggesting that some of these triple positive patients have an anti-prothrombin antibody that activates platelets. And that's probably the problem. And if you're on warfarin, you actually reduce the level of prothrombin. So presumably you reduce this activity. So there's probably something for some patients who've got these anti-prothrombin antibodies where warfarin is a superior drug. But they tend to be the triple positives who have this anti-prothrombin antibody. Whether we'll be able to get clever at it going forward and be able to do that test and show that only people with anti-prothrombin antibodies need warfarin, that would be useful, wouldn't it? But we don't have that. We don't actually do that test in laboratories at the moment.
Okay, so if you were checking levels on your patients with DOACs and the levels were coming out too low, they're asking, would you stop the DOAC at that point, or would you increase it off license?
So which of those questions was it? That was creatinine clearance one, was it, or?
No, so this is the top one here now about.
Oh yeah, would you stop it? If the levels are low, it depends on what, as I say, nobody really knows definite. We do give quoted ranges of what's prophylactic and what's therapeutic, etc. But there's, I think personally, if something's a bit below therapeutic, but I'm not overly worried about the patient, I'm happy with that. I think when you check levels, you're looking for a ballpark figure. You know, is it super low, or is it sort of okay in the middle, or is it super high? I think that to interpret it more than that is difficult. And also people do troughs and peaks, and some people believe more in troughs. I'm more of a peak person because I think it's easy for patients to have peak levels because they can take their morning dose and then have a peak done 3 hours later. And I think sometimes the troughs are perhaps, you know, they're quite low, and I don't know what that means, because if you did a trough on heparin, you don't mind putting a patient on heparin. If you did trough level, it'd be unrecordable, but it doesn't mean heparin doesn't work. So yeah, I'm more of a peak measurer. But I think if it was really low, I would think about changing. Yeah, absolutely. I mean, if you're going to measure a level, you got to accept the result. You can't just do it and then ignore the result.
Okay, so if someone's got a creatinine clearance of 15 to 30 mils a minute, diagnosed with a VTE, are you confident with using DOACs, particularly given the high initial loading dose? Yeah, so or would you consider warfarin?
I mean, that's a good point. So in the apixaban study, you had to have a creatinine clearance over 25 to be enrolled in it. And I can't remember what the GFR was for the Riva study, but I suspect that was probably around that 30. So actually, patients with creatinine clearances of less than 25 were not put into the studies. What I tend to do with these patients is I put them on heparin for about at least 5 days, and then I stick them on half dose of doxaban, 30 milligrams, often because you don't have any loading dose and you can go immediately onto the frailty dose. So I've done that a few times. But yeah, you can't start them on low doses of, say, rivaroxaban or apixaban. You've got to go through the process of the 10 BD or the 15 BD, then drop down to either 5 BD or the 15 or 20. You know, you can't, you shouldn't sort of mix and match against the trial and the licensing. But you can, you can say with a docs, you can go straight to a frailty dose after 5 days of. Yeah,
that's good to know.
The bigger trial will be a no, because you need a creatinine clearance above 100, above 50, because you've got to use 150 BD.
Okay, so if someone needs to be treated with deltaparin for VTE, but they've also got poor renal function, would you monitor the 10A anti-10A levels? And if you would do.
Yeah, I mean, only if they're end stage renal failure, I might do it. If they're dialysis dependent, I'll probably maybe do at least one level. But if they're not dialysis dependent, we tend to just modify it based on creatinine clearance. So we would tend to use, say, 1 milligram per kilogram, say if we're using enoxaparin, if their creatinine clearance is below 30. But if they're dialysis dependent, we sometimes use 0.75 milligrams per kilogram. But yeah, I think if you're bad, if your renal function is really bad, I would probably check a level, yeah.
Would you check levels in extremes of weight as well?
Very occasionally would do that if it was really extreme. What we tend to do for the extreme of weight in terms of high weight is we do modify the dose. If they're more than 140 kilograms, I'll modify the dose because of that issue about the vascularity of adipose tissue and the risk of overdosing.
So how would you investigate patients who have unprovoked DVT after 28 days following AstraZeneca vaccine without any other risk factors?
Yeah, so, I mean, what we're saying at the moment is if anyone comes in with any sort of thrombosis within the first 4 weeks of the AZ vaccine, is make sure you check the platelet count, make sure you do a D-dimer. If the platelet count's normal and the D-dimer is just the usual D-dimer, then it's going to be an incidental thing probably, because people will still get their clots. Even, you know, millions of people have their vaccine. People will get clots that are unrelated to that, as they always have done. But the ones that have got the syndrome generally have low platelets and incredibly high D-dimers, more than 4,000, which you don't normally see very commonly with standard clots. So I think it's about just making sure you pay attention to those two parameters, platelets and D-dimer. And if they are abnormal, then we are recommending going on doing this PF4 antibody test as well, which is usually positive, so occasionally negative. We don't fully understand the syndrome yet. There's more to it than we think at the moment.
So last question now. Are there any studies or any evidence at all regarding Thunderparanox being used to treat clotting in COVID, and what doses are optimum? I
mean, people have been using it in COVID. For, you know, if someone's got hit or something like that. I mean, the dosing regime is set already. It's 7.5 milligrams if you're over 50 kilograms, and it's 10 milligrams if you're over 100 kilograms. So there's a weight-based dose regime, and it's just as effective as heparin is. You can measure levels as well if you want to. It's got a longer half-life. That's one of the problems, in that if you're, say, on ITU and you need procedures doing, it's a bit easier to manage heparin because it's got a shorter circulating half-life. So you can do procedures 24 hours after a therapeutic dose, whereas it's a bit more tricky with Thunderparanox because the half-life is a lot longer. The half-life is 24 hours actually, almost. So it does take longer to get out of the system. But in terms of efficacy, it's very good, and it's got a dose regime.
Okay. I think that is your lot. Thank you so very much for your time.
Is this the end of is this the end of the day, is it?
One last one.
Oh, when's that start?
In about 5 minutes.
All right. Oh, sorry. Anyway,
no problem.
Thanks very much.
Thank you so very much.